Okay, well, let's get this show started. Without further ado, please welcome Dr. Amir Mohamad. Dr. Mohamad, welcome.
Much, Thank you so much, Robert and Marian. It's a pleasure to be with you guys today. So, for those who don't know me, my name is Amr Mohamad. I'm an assistant professor. I'm a GI medical oncologist and specialize in neuroendocrine tumors at UH Seidman Cancer Center in Cleveland, Ohio, at Case Western Reserve University. So today I would like to talk to everyone about what are neuroendocrine tumors, how we can diagnose them, what does it even mean to have a neuroendocrine tumor, what is the treatment options that we have, and what is the importance to have a multidisciplinary team. So I don't have any disclosure for this presentation. So the first question that we always ask ourselves, how is our neuroendocrine tumor patients present to our clinic? Definitely, they are very heterogeneous cancers, which mean you can have a lot of different presentations. But I found one of the most common three scenarios that most of our neuroendocrine tumor present will be either having the typical features of what we call carcinoid syndrome, flushing, diarrhea, wheezes, or patients most probably has been misdiagnosed for a long time. They're having what we call an irritable bowel syndrome, symptoms, and they have not been diagnosed appropriately from the first time. We can find that most patients can go delayed up to 5 to 8 years until they got real diagnosis with neuroendocrine tumors. Or some patients does not have any symptoms. Basically, they went for another screening procedures or something like that. They found either lesions in the liver or maybe lesion in the small bowel when they did a colonoscopy with what we call the ileum exploration. They got the biopsy, and here they found that they have neuroendocrine tumor. So after that, again, they got their labs, their imaging, and the pathology came neuroendocrine tumor. And the patient come to me in the clinic with thousands of questions in their head. So being diagnosed with cancer, it is a very stressful situation for the patient and the caregivers. I think being diagnosed with neuroendocrine tumors are definitely more intense and stressful because you're dealing with the unknown. What does it mean that I have neuroendocrine tumor? Does it even mean that I have a cancer? Is that some malignant tumor or just a benign tumor? Some patients come to my clinic and say, I have been told I have a benign tumor. I have been told I have a very, very rare tumors. Are these tumors even common tumors or not? What does it mean that I have carcinoid? And what is the difference between carcinoid and neuroendocrine tumor? And what's my treatment options? As you can see, a lot of questions. And I need to sit down for a minute and discuss to my patients, what does it even mean that you have something like neuroendocrine tumor? So neuroendocrine cells, if you split the sentence to neuro and endocrine, that means that there are two systems in your body, the nervous system and the endocrine system. So these are very, very small cells that need nerve stimulation so they can produce hormones. These cells can be anywhere in your body, not only in the endocrine system. Endocrine system is the system which is helping your body to produce hormones, like thyroid gland, like pancreas. But that doesn't mean that they are only in these organs. They can be in the small bowel, they can be in the colon area, they can be in the ovary, so in many other organs, in the lung. But these are very, very small cells which need nerve stimulation to produce hormones. And here is where the name coming, neuroendocrine cells. The neuroendocrine tumors can be found anywhere in the body. Can be in the lung, can be in the small intestine, can be in the pancreas. The most common, if you're going stepwise one by one, will be the small intestine, what we call the small bowel neuroendocrine tumor. After that will be the lung and the pancreas, and you can see what we call the small bowel and pancreas, which is the gastroenteropancreatic neuroendocrine tumor, almost about 70% of our cases. And this is why most of the NET experts are a GI medical oncologist in the same time. So coming to the next questions, are these rare tumors? The concept that neuroendocrine tumors are rare tumors has been in the mentality of many patients and physicians for a long time. But what you can see here in the last 25 years, neuroendocrine tumors are significantly rising. I think more than 7 to 8 folds in the last 25 years. We cannot say that all of them are new cases. I think we have much better modalities. We have a lot of imaging modalities that I'm going to share with you in a second. We have a great pathologist that we can really pick these tumors at earlier stage. So we can discover more and more neuroendocrine tumors. And again, they are slowly growing tumors. The patients can live a long time. So basically, it makes the incidence and the number of cases rising significantly in comparing to other cancers. Still, it's lower than colorectal cancer, lung cancer, breast cancer, but the numbers and the awareness are significantly rising recently. There are many terminologies, and every of them represent a different identity of disease, which mean neuroendocrine tumors, they are not all the same. Carcinoid, we are going to take what is the history of the terminology. Carcinoid is different from neuroendocrine tumors in other organs, are different from what we call neuroendocrine carcinoma. So we need to understand what does every one of them means exactly so you can understand your disease better. So coming with carcinoid, it's a very old story actually when you look at the history of carcinoid. About in 1907, Dr. Opendorfer, who is a pathologist, discovered these very small cells, which does not look like normal cells, but he also describes them as a cancer-like cell, what we call carcinoid, which is cancer-like cells. They're different from the small cells, but he describes them as a harmless cells. They are not behaving like other malignant cancers. Obviously, we know now that that's not really a very accurate description of neuroendocrine tumor because they are actually cancers, they are malignant tumors, but they maybe behave different than other cancer because they are slow-growing tumors. But this is where is the history coming from, the terminology of carcinoid. And then after that, maybe 7 years after that, Dr. Gossett and Mason, they describe the secretion property of this cancer, that this cancer need nerve stimulation and they producing hormones. And this is where is the name or the character of neuroendocrine tumor came. And it took them a while, almost until 2000. You can see that almost 100 years, until the WHO put a good description or definition of what are neuroendocrine tumors. They are slow-growing cells, but they are not the same disease. They are very heterogeneous. They can be a very slow-growing, lower-grade neuroendocrine tumors, or they can be a very aggressive cancers as well if they are in the higher grades. And we are going to discuss what does it mean by differentiation and grade in a minute. When it comes to symptoms, the most important thing I would like my patient to understand is your tumor is functional or non-functional. To make it very easy, does the tumor do its function? Does it produce hormone to cause you having symptoms? Or basically, it may be producing some hormone that we can detect in the blood or the urine, but you do not have the symptoms. We still call it non-functional. So the definition of function is not only the level of the hormone in the blood, but it's also, does this hormone causing you to have symptoms or not? For example, if you have a small bowel neuroendocrine tumor, or sometimes bronchial, what we call lung carcinoid, they're producing serotonin, and the patient will start having flushing, diarrhea, wheezes. We call this is a functional small bowel neuroendocrine tumor. If someone coming with pancreas neuroendocrine tumor, which usually the pancreas by itself can secrete insulin, but by this tumor, we have an extra insulin secretion. So the patient start have low blood sugar, so start having all the symptoms of what we call hypoglycemia, or if the patient having a high glucagon, which can, the opposite of insulin, can increase the blood sugar. So the patient having, like a high blood sugar for a long time with really no specific reason why he has this high blood sugar. The patient can have a lot of ulcers, in the small intestine or the stomach, what we call the gastrinoma. And this can be coming from the pancreas or the small intestine. This is all hormonal secretion in addition to symptoms. What we call it, this is functional neuroendocrine tumor. So as you can see here in this graph, this is the most common carcinoid features, including diarrhea, wheezes, flushing, and this is all caused by serotonin. Serotonin is a hormone which can be produced in our body, can causing what we call vasodilation, which is making the blood vessel dilated, so you have more gushing of blood. So basically the patient start have flushing. It also can increase the motility and the patient can have diarrhea. And about 19% of the cases, if the hormone is very high and it's going to the right side of the circulation, it can go to the heart and can affect the right side of the heart valves, what we call carcinoid heart disease. And then the patient will start coming with difficulty with breathing, shortness of breath, coughing, with any exertion, they're feeling very fatigued. And here is coming the multidisciplinary importance. You need to have a cardiologist who already saw a lot of neuroendocrine tumors and carcinoid heart disease. You need when to order an echo for these patients, when we are going to intervene medically, and when we need to replace the valve surgically. So it's the multidisciplinary team is very important to follow up this patient with you from day number one. So how do we diagnose neuroendocrine neoplasm? And the first thing come to any patient has been diagnosed with cancer, what is my stage? Stage is still very important information for all our neuroendocrine tumor patients. But in addition to stage, these specific unique characters are very, very important for neuroendocrine tumors. It definitely differs the groups of diseases of neuroendocrine tumor. Everyone is different according to this information. But also its impact is the treatment and the prognosis of our patients. So the patient needs to really understand when they look at their pathology report, what does every single word mean? So they know what is the disease behaving and what are their options. So when I call a good pathology report from a pathologist who are net expert, who know what are neuroendocrine tumors, I need to look at the three important information in addition to the stage and where is the cancer coming from, what we call the primary tumor. Number one, the stain, the cell with the specific stains to differentiate neuroendocrine from other types of cancers. What are the differentiation and what is the grade and what does it mean? We need to talk in that in details. So the stains, there are specific stains we use for neuroendocrine. It's something like somatostatin and chromogranin, just to let us know that these cancers that we got the biopsy from are neuroendocrine neoplasm. After that, I always sit down with my patient and discuss what are differentiation and grades mean. Differentiation, just to make it very simple, how is these cells looking under the microscope comparing to the normal primary cells they are coming from? If they are basically well behaved, well organized, maybe some changes from the normal cell, but still you can identify the group of cells and the main characters, we call it well differentiated. If they are very aggressive, different looking, we call it poorly differentiated. Why is that important? Because definitely they are completely different disease. We are going to see in a minute that well differentiated have an options of treatment and options of behaving and prognosis completely different from poorly differentiated, which unfortunately we do not have a lot of treatment options, and we took most of our treatment option chemotherapy from other aggressive diseases like small cell lung cancer. After differentiation, it's very important to understand the grade. So what is the difference between differentiation and grade? So differentiation, how the cells looking like. Grade is basically how fast they are multiplying. So our pathologist will, using specific stain called a Ki67, sometimes they use something else called mitotic index, and usually you may find only one of them in the pathology report. Depend on which one of them is higher, most probably they will report as a higher one. So Ki67 is simply a protein which gives you an idea how fast are these cells multiplying. It's very important because every grade it behaves differently. At two cases of the small primary, maybe pancreatic neuroendocrine tumor, maybe having the same stage, stage 4 went to the liver or other places, but the grade can make a big difference in how we treat these patients. So if the Ki67, the number I would like you to understand is 3 to 20. Anything less than 3, we call it grade 1. Anything between 3 and 20, that's a grade 2. And anything more than that, than 20, that's a grade 3. And you can see these brown dots here, which is interesting until now. In addition to the digital imaging, sometimes the pathology will count that manually. So you can find that the pathology report comes from outside, with a Ki67, maybe 15 or 18%. And then when our pathologists repeat it again, you maybe can find it more than 20%, which will make the grade different, which may definitely impact how we are going to treat you. So it's very important to understand from the pathology report, what is the stains, as we said, somatostatin and chromogranin, what is the differentiation, and what is your grade. It was until 2019, before that we always saying that any grade 3 neuroendocrine tumor is basically poorly differentiated, which is very, very aggressive. But then we found recently with the WHO that no, that's not really the case. Some grade 3, which is still, we call it high grades, are considered well differentiated. So still the Ki-67 is more than 20. Most of the cases we see it more than 20, less than 55%, but there is no distinct number to differentiate, both of them until now. But the differentiation is well differentiated. Sometimes you treat these patients as the same like the intermediate or lower grade if they have specific receptors and specific characters that we can treat them the same like the lower grade. However, if you have a grade 3 poorly differentiated, definitely the options are completely different. So it's important when the pathology report mention high grade, we need to ask ourselves, what high grade does they mean? Is the high grade well differentiated, what we call NETs, neuroendocrine tumors, or they are high grade poorly differentiated, we call it NEC, or neuroendocrine carcinoma. So this will bring us the names to the, again, we discussed that the carcinoid are not a very, very accurate name. We still use it for small bowel and sometimes bronchial, which is the lung, because they are secreting hormones. But the accurate name is the neuroendocrine neoplasms, which is the general umbrella of all the neuroendocrine cancers. And neuroendocrine tumors are considered the well-differentiated. Neuroendocrine carcinoma are the poorly differentiated. Even well-differentiated can have a grade 1, grade 2, and even grade 3. So even higher grade doesn't usually mean that you have a poorly differentiated. It can be a higher grade 3, well-differentiated, still we call it neuroendocrine tumors. The first question should come to our mind of any patient who has been diagnosed with neuroendocrine tumors. Where can I find a comprehensive NET program? The treatment of these tumors is definitely not one-man show anymore. It is basically, do you have the right person in every subspecialty or not? Do you have a good pathologist who are going to give you a very comprehensive report? What is the stains? What is the differentiation? What are your grades? Because it definitely will impact your decision for treatment. Do you have a gastroenterology who can, sometimes we cannot find what is the primary tumor. We only find some liver lesions, but no primary tumor. We need a gastroenterologist to go and do a specific colonoscopy, capsule endoscopy, upper endoscopy, just to help us finding what is the primary tumor, which is also very important for choosing your therapy in these patients. You need to have a good cardiologist who see a lot of neuroendocrine tumors, who need how often they need to order the echo when we are going to intervene medically or surgically. So definitely that's very important. You need to have a good nuclear medicine team who can review the imaging with you and show you the intensity of what we call somatostatin expression that we are going to discuss in a minute. You need to have a very good surgeons as well who already treated a lot of neuroendocrine tumors, because even in the metastatic setting, what we call the stage 4, we still have an options of surgery to treat our patients, because it's different than other cancers. They are slow-growing cancer. By doing surgery sometime and removing as much as you can, what we call cytoreduction, you can reset the clock, and you can improve the survival of the patient and definitely improve the outcome. So the key is the multidisciplinary team, all of them having an expertise in neuroendocrine tumors. So the first thing after we got the diagnosis, what type of labs should I have and what type of labs should I follow up with? So chromogranin is a very common tumor marker, and unfortunately it is not the best tumor marker we use for neuroendocrine tumors. A lot of medications and food can affect the level of chromogranin. I'm not surprised when a lot of my patients, diagnosed with only localized neuroendocrine tumor, and we remove the cancer and the scan showing that there's no any disease, and then you do the chromogranin A, you find it like triple what it was even before doing the surgery. I'll give you an idea that chromogranin A level will never impact my decision in getting imaging early or treat the modality of options of treatment that I choose for my patients. I always tell my patient it's not a very good tumor marker to keep relying on for your follow-up. Some physicians, like we order that as a baseline, but even if I order that as a baseline, I need to discuss to my patient that's not the best tumor marker we follow up with. If the patient have a small bowel or bronchial carcinoid, and they having the features of what we call carcinoid features, including wheezes, diarrhea, flushing, we go ahead and we order what we call the serotonin level. The serum serotonin level or the blood serotonin level, it is not the best accurate test because the serotonin is hormone in your body that basically can fluctuate in 24 hours. So you can get two samples on the same day, but different times you find different values. So he's using for a long time the urine 5-HIAA, one of the components of the metabolism of serotonin, and basically was slightly inconvenient for some of our patients. You give them a jar, and they have to be for the jar for 24 hours. So you can imagine that that's not very convenient, but definitely more accurate than the serum serotonin. And now we're having the plasma 5-HIAA in the blood that we ordered for our patients, much easier to get. What type of labs I need to get if the patient has pancreatic neuroendocrine tumor? We know that these are the hormones can be produced with pancreatic neuroendocrine tumors, but you don't need to have all of them if you have just a pancreas lesion and has been diagnosed with neuroendocrine. You are going to order any of these hormones according to the symptoms that you have. So it is symptoms driven. It's the same like small bowel. If you don't have the symptoms of carcinoid, you obviously don't need to have a serum serotonin level, because even if it is high and you don't have the symptoms, I still will call it non-functional tumor. For the pancreas, if the patient came to me with low blood sugars for a long time, sweating, rapidly heart beating, some symptoms which tickling my brain that there is something wrong is going on with insulin, I will order definitely fasting insulin, pro-insulin, and C-peptide. If this patient coming with a high blood sugar, ordering the fasting glucagon will be the right test. If they're having a lot of ulcers in the stomach, in the small intestine, for a long time without any reasons, they are not in a specific medication to increase the risk of ulcers, I will go ahead and order gastrin. And it's very important, again, to be fasting and they're having some precautions before you do the test. There's some medications that you need to stop for at least a week and stuff like that to make sure that we have an accurate test. So always ask your physician, what is my precaution that I would like to have before I go ahead and have my test. And these also another hormones can be secreted not only by neuroendocrine tumors, other cancers as well, especially if someone having high calcium for a long time. We need that specific PTHRB and other hormones can be checked just as occasion if you have the symptoms to driven me to order this type of test. And again, these are precautions not only for the 24-hour urine, but definitely for the other hormones as well, including specific food that you need to be away from, specific medication which can interfere with the blood test or the urine test. So definitely ask your physician what is the precautions and what is the food or medications that I need to be away from. When it comes to essential imaging, that's very important. So we already got the lab, and what we are going to ask ourselves, what is the essential imaging I need to have? So definitely doing a CT scan or MRI, this would be very important. I have been told only I have 10 minutes, so I need to go faster. Other imaging that's very important is the gallium-68, and now we have something called the copper-64. And both of them will showing you what we call the somatostatin receptors. They are more specific than the anatomical imaging. It's very important to know what are your somatostatin receptors. So basically, we can take our decision of treatment according to that. So if we go to what is our options of treatment, again, surgical debulking or removing as much as we can, it's still one of the options. You need to have a very good surgeon who expertise in even treating neuroendocrine tumor in the metastatic setting. Liver embolizations with different modality is different, one of them. And the systemic treatment, there is with coming the rule of the medical oncology. When we are going to discuss what options of systemic treatment, there are four principles we choose our treatment according to that. Do you have the somatostatin receptors or not? If you have them, the specific somatostatin analog, what we call the octreotide or the lanreotide, definitely are an options. Now we have what we call the Lutathera or the PRRT. We are going to discuss that in a minute. Specific targeted therapy, if you have a specific mutation, mainly for the patient with pancreatic neuroendocrine tumors. We're targeting the expression of the genes for the blood vessels because neuroendocrine tumors are very hypervascular tumors. They depend on the blood vessel for growing, or chemotherapy if we're having more aggressive disease. So to make it very easy, what are somatostatin receptors? I describe it as a lock. Do you have a lock on the surface of your cells or not? If you have that, we have the key to diagnose you using what we call the gallium-68, attaching a radioactive material, so we can show these receptors. But also we have options to treat you as well. We can attach the receptor with a specific somatostatin analog to attach to it to hopefully decrease the hormonal secretion and delay the growing of the tumor. Or recently, we can attach to the somatostatin material a radioactive material as well, which can definitely deliver a very targeted radiation. This is what we call the PRRT or the lutetium. So what are somatostatin? It's a hormone which basically decreases everything else. It can decrease gastrin, insulin, and all other hormones. Your body is secreting this hormone naturally, but the problem, it's only working for 1 or 2 minutes, and it doesn't make sense to give a patient treatment every 2 minutes. So we're having a new analog, something like somatostatin, called somatostatin analog, that we use it definitely in any patient have stage 4 or metastatic, well-differentiated neuroendocrine tumors from any primary origin, basically, but definitely the patient need to have the somatostatin receptor in the gallium-68 imaging or the copper-64. It decreases the hormone secretions, so it decreases your hormone level, it improves your symptoms, but that's not the only reason. Even if you don't have symptoms, we can use it to decrease what we call the progression of your cancer. There are 2 phase 3 trials has been done and showing it definitely decreasing or delaying the growth of your cancer. So this is why we're using somatostatin analogs. If you're still having symptoms, diarrhea and flushing, we can control it with many other options. And these options include what we call the short-acting octreotide. Now we have the pen version, which is much easier. You can give it yourself 3 times a day. You have the telotristat, one of the medication we use, and we have the amino acid Intrade, one of the amino acid drink that also can help decreasing your diarrhea. And this is 2 of the slides showing that telotristat definitely was decreasing the diarrhea and the flushing if the patient is still having these symptoms after somatostatin. What is the PRRT or lutetium? Again, very briefly, it's a somatostatin material attached to radioactive material, will go inside your cells and deliver very concentrated radiation. It definitely delays the progression of the cancer. It was very, very significant, more than 79% decrease the risk of the cancer progression in a phase 3 trial. We need to understand that the response wasn't that great, only 18%, but definitely the main reason it is delaying the progression of your cancer. We use it now as a second line if you have a somatostatin receptor of what we call gastroenteropancreatic. The targeted therapies that we have, the mTOR, basically it's a protein which regulates the cell growth and the proliferation or growing. If it is activated or dysregulated, it can lead to many cancers, including neuroendocrine tumors. So everolimus is one of the medications that we use for that. Many trials has been done for different primary and showing definitely delays the progression of the cancer as well. So everolimus will delay the progression, response not that great, still less than 5%. The strongest data that we have for the pancreas, but if you have non-mid gut as well, colorectal and lung, we definitely can use it. The weakest evidence was in the small bowel. So you can see knowing what is your primary tumor is very important for choosing the treatment. Sutent or sunitinib, basically, it's a medication which targets the blood vessel, and we use it mainly for pancreatic neuroendocrine tumor. You can see definitely it delays the tumor growth as well, so it delays the progression of your tumor. We use it mainly in the pancreatic, stabilize your growth of the tumor. The response is still not that great, less than 9%. Which one should I use, everolimus or Sutent? Definitely depend on what you have. So if the patient having hypertension, cardiovascular disease, Sutent can causing a lot of hypertension complication. Everolimus would be a better option. If you have diabetes, everolimus can cause hyperglycemia, so we use Sutent at this time. So depend to discuss with your physician what type of comorbidities that you have will definitely affect what type of treatment we'll give you. The last thing I want to show here is the chemotherapy in 2 clinical trials using capecitabine and temozolomide will definitely improve the progression-free survival and the overall survival of our patient. The main reason why we use it is basically to decrease the size of your cancer. You can see the response here. It's definitely great using this specific type of chemotherapy, the CAP-10. We use it sometime in stage 4 to decrease the amount of cells until we can even do some surgery after we decrease this amount of tumor burden. We use it mainly for pancreas, but still definitely have an option for small bowel and lung, but not the same response as pancreatic neuroendocrine tumor. What is the future treatment that we are looking for? The same principle. Somatostatin receptors is mainly somatostatin analogs and antagonists will come into the market soon. We have the alpha targeted therapy, which is basically one of the very promising treatments. We have the same the anti-angiogenesis and the targeted therapy. These are a medication called surafetinib is going to also come to the market hopefully very soon. We have the cabazantinib, another medication in a phase 3 trial right now, and also using immunotherapy in addition to other targeted therapy definitely can be an option. To summarize everything, again, you need to understand your disease very well. They are very heterogeneous disease. The key, again, is the NET program, different subspecialty who are having expertise in neuroendocrine tumor, and very, very exciting times that we're living right now with all these options that we have. So definitely 20 years ago, we did not have any of them. So for that, I will come to the end, and I would like to thank you, everyone.